morning, everybody. Good morning. We're just about to start. Thank you very much, everyone being so prompt coming in this cold morning. Good morning. My name is Gráinne Healy, and I'm going to be facilitating your conference today. I want to welcome you all. Sharing the Vision Mental Health Policy Conference 2024. I think you will appreciate the amount of planning that has gone into today, and I know we were oversubscribed, which is always, I think, a good sign, and I'm delighted to see so many colleagues here. In welcoming you, we just wanted to say to you that there are the hashtag sharing the vision, should you want to I don't know what they call it now, tweet, X, whatever it is they call it these days, and also the hashtag no health without mental health, which I think is a very apt one for today. Just to say a little bit of housekeeping, we will be recording but not live streaming the event, and it will be available then in a couple of days on the website for those of you who might want to look back on it or share it with colleagues. Also, saving the planet and the forests, there is a little QR code on each table, which if you have your little QR code on your phone, you can take a snap of that and it will bring up the agenda for the whole day. So again, a good development, I think, in terms of sustainability practice. I do have a very short safety video, which I'd now like your attention for. Thank you.
Ladies and gentlemen, may we please have your attention for this public safety announcement. This is the main conference hall. The conference hall has 3 emergency exits. Exit signs will remain illuminated at all times. Please take a moment to check the exit nearest you, bearing in mind that it may be behind you. In the event of emergency, you will be asked to proceed to the exit and move up the stairs to the assembly point located in the lower castle yard beside the church. For your convenience, restrooms are located outside the main entrance to the room. Please ensure that mobile phones are switched to silent while in the conference hall, and remember that Dublin Castle is a no smoking and no vaping building. If you are using headsets, we would request that you return them to where you found them when you've finished.
Okay, so we're all clear on that. Thank you very much. So our purpose today, as you know, is to gather so many practitioners and policy developers together in the room to share experience, to look back. This morning we will be looking back at NIMC and the work it has done, and also looking forward. And I'm also delighted to say that we have some excellent keynote speakers bringing some international perspective. But a lot of today will be about those of you who are working together and sharing, having the opportunity to look at what's working well and to look to the future to try to continue the delivery of sharing the vision. So to start us off this morning, I'm delighted to introduce the Minister for Health and Older People, Mary Butler, who's going to speak to you and will also then introduce a short message from An Taoiseach. Minister, you're very welcome.
Dias Miracle Galir Tá an áthas orm bhain seo modulin you. Good morning, everybody. It's absolutely fantastic to be here in Dublin Castle in the Hibernian Centre to open this conference today. Sharing the vision, a mental health policy for everyone. I suppose it has become my Bible. As Minister for Mental Health and Older People, I have a couple of Bibles, and the mental health one is this, on my desk at all times. I delve into it every couple of days. Very hard document to read in its entirety, but I delve into it every couple of days, and then the phone is picked up to my team, and they say, here she goes again. And look, from the outset, I just want to welcome each and every one of you for making the effort to be here today. It's absolutely fantastic to see so many people present in the room. The weather is not great, it's an early start, and I do really appreciate everyone who has made an effort to be here today. I want to welcome all my colleagues in the Department of Health. I want to welcome all my colleagues in the HSE. I want to welcome all our NGO partners. And I've made so many friends over the last 3.5 years as I look around the room. I also want to welcome Oireachtas colleagues here today. I see to my left, Deputy Cathal Barry is here. Cathal Barry, and there'll be many more coming in and out during the day. And I just think it's fantastic to see so many people here. It's our first ever conference in relation to sharing the vision. And I think it just speaks of how important the area of mental health is. Mental health is an issue that affects us all, and it is an area of utmost priority for me and the government. Today's conference gives us an opportunity to reflect on 3 years of policy delivery. It's hard to believe it's 3 years under sharing the vision, our national mental health policy, and to look forward to the next 4 years with renewed focus and energy. As I've said, I'm so pleased to see so many people here today who work every day to deliver essential mental health services, to improve those services, to advocate for service users, to examine what we can do better, and we can always do better, and to champion the issue of mental health in the public domain. It is vital that we recognise mental health as something which cuts across all aspects of life. I firmly believe that mental health is everyone's business and everyone's responsibility, and I am glad to see that message be put across in the work we do every day. This all underpins today's message, which is, there is no health without mental health. There is no health without mental health. This is a fundamental principle of our mental health policy, which is a whole of population and whole of government in its focus. This means, firstly, that this is a mental health policy for everyone, and secondly, that delivery on this policy is the shared responsibility of government departments and agencies. And it is important to recognise the progress that has been made in the area of mental health in recent years. I became Minister for Mental Health and Older People in 2020, July of 2020. Our new mental health policy, Sharing the Vision, was launched in June of that year. Also, COVID was launched in February of that year. And I think we're at the stage now that sometimes we forget what COVID was and how difficult it was. And our goal at the time was to enhance and improve mental health services and supports across the board in Ireland over the following 10 years. But COVID intervened. COVID intervened, and we had to adjust very, very quickly. And by God, did we adjust quickly. And I want to pay compliment to each and every person in this room who worked tirelessly during that time to deliver services. And I am so proud as Minister to be able to stand up here and say that during COVID, 85% of all mental health services and supports remained intact. And there's not many organisations can say that. And during COVID, I think the recognition was there that this was a time when people's mental health was impacted, their emotional well-being was impacted, their peace of mind was impacted. And it was really, really important. And all our partners, they pivoted so very, very quickly. And hey presto, all of a sudden, what we spoke about for years happened. We went online. And we reached out to people in their bedrooms and in their kitchens and in their back gardens. And we supported people to look for help. And most importantly, we supported those people that never asked for help before. We supported those people that were afraid to reach out. We supported people who were living in abusive relationships, and they were able to go into their rooms and they were able to contact all our various organisations. And I want to thank each and every one of you for doing that. Sharing the Vision is a complex and far-ranging policy. It focuses not only on the provision of mental health services, but also in the key areas, promotion, prevention and early intervention. And I have to say, when I became Minister first, and I had been previously spokesperson on older people, I spent a lot of time trying to get into the weeds of sharing the vision, and I want to thank everyone that supported me at that time. And I really felt it was very, very important to understand what was the difference between sharing the vision and other mental health policies that came previously. And the difference was that this policy just didn't rest on a shelf someplace. this policy was going to be implemented. So the three things I took from it from the very start was, and I just want to mention the Assistant Secretary at the time who led me through these difficult times back then, Colin Desmond. He did Trojan work at the time during COVID. And I always remember my very first meeting with him, and I said to him, what's the difference? And he said, the difference, Minister, is that sharing the vision is patient-focused and patient-centred. For the first time ever, he said, we're talking about dual diagnosis is going to be accepted across the board. What also is different, he said, we're going to listen to lived experience. We're going to talk about peer support. But the third thing is, he said, we're going to have a national implementation and monitoring committee, and it'll hold you to account, it'll hold the department to account, and it'll hold the HSE to account. And that was the difference. And here we are 3 years in, after having a difficult 3 years in relation to COVID, a difficult 3 years in relation to issues that we have dealt with in relation to the provision of service in CAMHS, but also a lot of progress after being made. And sometimes we do have to celebrate and we have to acknowledge that a lot of good work is done every day of the week in mental health. I have really good news, and I'm kind of bursting to get it out there. I'm not meant to say it later in the speech, but I normally go off script when I'm speaking, and that's what I'm going to do now. So, firstly, I want to say that I am very, very lucky to have the full support of the Minister for Health, Mr. Stephen Donnelly. From day one, he has supported everything I have tried to achieve in mental health, and he has also helped me, I suppose, get the necessary funding that's needed. I didn't make any secret of the fact for Budget 2024, even though our mental health budget for this year is €1.3 billion, a phenomenal amount of money. Since I came to post, an increase of 25% for mental health funding over 4 budgets. I can't believe I've gone through 4 budgets, but I have. And I have the grey hairs to prove it. Difficult times. But I didn't make any secret of the fact that at budget time, even though there was an increase in funding, I personally was disappointed with the amount of funding I secured for new developments for mental health for 2024. And today, I am delighted to announce that working with Minister Donnelly and working with Cabinet and the Government, more additional funding for mental health is being announced today. A further €10 million has been secured for new developments. This is not part of the 80 million additional funding that was announced in budget for Budget 2024. This is an additional 10 million for new developments. And I'm absolutely delighted because this means we can put an additional focus on youth mental health, on CAMHS, on waiting lists. So I will meet starting tomorrow with Minister Donnelly and Dr Amanda Burke, our clinical lead. We will start our meetings tomorrow to plan for the most impactful way of using this additional funding. So I'm not going to keep going until I get a boola bus for an additional 10 million. €10 million for new developments. So for new developments, for something additional that we weren't able to provide previously, that's massive. And that means a lot of the clinical programmes, we'll have much better news for them. And I see Dr Amir Niazi beaming from ear to ear, sitting down there in front of me, and a very, very happy man today, and I'm a very, very happy minister. As you know, we had secured additional funding for 68 posts across CAMHS, as well as posts for eating disorders, dual diagnosis and early intervention in psychosis, and further support for the CAMHS Hubs pilot. But this means we'll be able to do more, and we will start very, very quickly, and we will do more very, very quickly. As you know, 5.6 million has been allocated to our national clinical programmes in mental health services in the last 3 years. And across these programmes, 120 staff have been recruited since 2020. Recruitment of funded posts is virtually complete on the clinical programmes on adult ADHD. When I came into post, we had no adult ADHD teams, none. We now have 5 in place and 2 more being recruited. That's 7. That's progress. Early intervention in psychosis, We have made great strides in relation to that, from Cork to Dublin, from Sligo to the Midlands, more to do. And also the management of self-harm and suicide-related ideation. When I came into post, we had one full eating disorder team in place, one. Notwithstanding the great work that had been done to try and get the clinical programme up and running, we now have 10 teams, 5 adult and 5 CAMS teams. 7 of them fully in place, 3 more being recruited and almost there. That is progress as well. I know it's slow progress, but it's making a huge difference to all those that receive the supports from them. I also want to touch on a couple of highlights as my time as Minister. My first piece of legislation was in relation to mental health. As Minister, related to the opening of the new state-of-the-art, new National Forensic Mental Health Services in Portrane. And this opened in November 2022 with a smooth transition of patients from the former Central Mental Hospital in Dundrum. It is a purpose-built facility, delivering on a programme for government commitment and a key objective of sharing the vision, providing a range of forensic mental health services to its patients. It is the best forensic mental health facility in Europe. It costs shy of €220 million. It barely got a mention in the media. It's a really, really important facility. And I just want to acknowledge a former colleague, Jim Ryan from the HSE, and I probably drove Jim Ryan insane for 2 years over getting that facility open. But we got there in the end, everybody working together in the department, the HSE and the PNE. We did get there in the end. But that is a fantastic facility for very, very ill people and patients that live there now and call it their home. And we have to acknowledge the fact that we did this. And, you know, it is an important initiative. Continued investment and recruitment allow us to progress a variety of mental health initiatives and to continue our work to transform mental health services in this country. And one of the reasons that we are here today is to mark a key movement or a key moment in the implementation of Sharing the Vision as we move from the first implementation committee to the second. The oversight structures of any national government policy are key to its effectiveness, and to this end I established the independent National Implementation and Monitoring Committee for Sharing the Vision in December 2020, putting in place structures. The NIMC Steering Committee provides clear guidance, oversight, coordination of policy recommendations. The NIMC has been expertly chaired by Mr. John Saunders over its first term from 2020 to 2023, and I would ask you all here today to acknowledge John Saunders and all his team for the phenomenal work that they have done. So John has steered the ship for the last 3 years. We meet on a quarterly basis. We discuss a lot of issues in relation to mental health, and I have to say I was always delighted and asked John for his opinion and for advice in relation to many things. And that's one of the things that's really important as a minister, that you do listen. And I am now delighted to say that the National Implementation and Monitoring Committee will be chaired for its second term over the next 4 years by Ms. Catherine Brogan. She's sitting down there. You'll all know Catherine from her work in Mental Health Ireland. She's known the length and breadth of the country. And Catherine, thank you very much for agreeing to chair the NIMC for the next 4 years. The delivery of the 100 Sharing the Vision recommendations would not be possible without the support of the HSE implementation group and the specialist groups which were established under Sharing the Vision. Specialist groups have been tasked with delivering on key priority areas such as women's mental health, acute bed capacity, digital mental health and youth mental health transitions. Identifying important themes is one way of supporting policy implementation, but an issue that is very important to me is that the voice of service users, their lived experience, is always taken into account. And that's why it was so important that the NIMC reference group of service users and family members was established in 2022. The innovation of the reference group structure has given the voice to service users, family members, carers and supporters, a central platform in delivering the policy. Good policy should never be implemented in a vacuum, and the importance of their role cannot be overstated, and I want to thank them for all the work they do. I am really I am really pleased to see that the reference group is represented here today, and again I say thank you. Ireland should be proud of the fact that our mental health policy is person-centred, recovery-focused and crucially concerned with improving outcomes for people experiencing mental health difficulties. A great deal of work and effort has gone into ensuring that policy delivery, lived experience and real outcomes remain closely linked, but also through the development of patient partnership and the work of the HSE Office of Mental Health Engagement and Recovery. And I know we're going to hear later on more about that. I am pleased to say that we will hear from Ms. Sharon Lane, Chair of the Reference Group. Michael Ryan, as I've said, we're going to hear in relation to health engagement and recovery. And I'm looking forward to hearing more about recovery, because that's the one thing we all have to be conscious of. Recovery is possible. Recovery is possible. So they're the two bylines today. No health without mental health, and recovery is possible. And I would like to also warmly thank our keynote speakers, Dr Lazeri and Dr David McDade, for giving their time to engage with us today. It is important that Ireland remains at the forefront of international discussions on mental health. I know I'm running out of time, I always do that, but I'll wrap it up now very, very quickly. As referenced earlier, youth mental health remains one of my core mental health priorities. We have listened to the experiences of young people, their families and clinicians in CAMHS, and undertaken independent evidence-based research with a view to understanding and constantly refining and improving our service provision. As Minister for Mental Health, what comes across my desk most days are in relation to youth mental health. Psychiatry, a later life, I think most of you will agree with me. You know, it's very well established. We can look after people very well. General adult mental health services. They run very well in the main. Challenges where you're transitioning from age 18 over. That's where the difficulties start. The fact that we're still using paper files. I've gone off script now and I'm going to be a little bit critical. The fact that we're still using paper files in a lot of places. So you're moving from maybe getting supports from an eating disorder team, or you might have suicide ideation or self-harming and you're with a consultant, CAMHS psychiatrist for 4 years. And then you're moving on to general adult mental health services and you're bringing a file that thick with you. And it's very, very difficult for that transition. So that's an area we're really looking at. I'm really pleased for the first time ever in the history of the state, we have a youth mental health office in the HSE led by Mr. Donan Kelly, and Donan will speak later on. And also I think one of the things we decided very, very quickly after the Maskey report in Kerry, that it was so important that we would have a clinical lead for CAMHS. And I want to thank Dr. Amanda Burke, sitting here on my right, for the work that she has done already. She has hit the ground running. And I know she's already ticking up in her mind how that 10 million will be spent. So I just wanted to say that very, very quickly, that those things are hugely, hugely important. So we have made progress. Finally, before I finish, I couldn't do this job without the people that are surrounding me every day of the week. I have a great team in the department, led by the Principal Officer, Siobhan Hargis, and by the ASEC, Siobhan McCardle. And Siobhan has a very, very busy job to do, because not only does she have mental health, she also has older people. So she has to listen to me twice every day. And I'm sure at times she says, not her again. But in fairness, we have a great working relationship. I also have a great working relationship with the HSE. I always had, and I just think it makes life so much easier that you can pick up the phone to whoever. I have a great working relationship with the NGOs. People ask me, why did I get involved in politics? Because politics can be very, very difficult. Yesterday I was in Carlow launching a dementia cafe for the people of Carlow called the Cabin Cafe. 30 people today. 30 people, there'll be 30 new cases of dementia today. There was 30 cases yesterday, there'll be 30 cases tomorrow. That's what gets me up in the morning, launching a new dementia cafe yesterday in Carlow to see all the people in the room with their lived experience. Today, being here in Dublin Castle for this fantastic conference to talk about mental health, to talk about what we're doing right, to talk about what we could do better, to talk about what we need to do more of and what we need to do more quickly than what we're doing already. That's what gets me up in the morning, and I can't do that work without the great team I have around me in my own constituency offices, in my own office in Leinster House, with my advisor, Crona Joyce. I want to give her a mention there. That does phenomenal work every day of the week. So I hope you're going to enjoy the conference today. It's a really, really important conference. We're going to hear from a lot of people who are tasked with delivering services on the ground. We're going to hear from a lot of people who have a lot more experience than I'll ever have. But take away the 2 points today. There's no health without mental health, and recovery is possible. Thank you very much. I forgot to do one job. I'm sorry about that. I would now like to introduce Taoiseach Leo Varadkar, who is going to address the conference, and I want to thank the Taoiseach for taking time out of his really busy schedule to do that. Thank you very much. Well done.
Good morning, everyone. I'm sorry I can't be with you in person today. As we all know, our mental health profoundly affects every aspect of our lives, and that's why it's remained a consistent priority of the government. It's estimated that 1 in 4 people in Ireland have a mental health challenge of some kind, and that many more will experience some mental health difficulties in their lifetime, with these ranging from mild to severe. I believe the pandemic heightened awareness of mental health as many more people experience feelings of loneliness, isolation, and anxiety. Sharing the Vision embodies that ambition and is being implemented thanks in no small part to the contribution of all of you who are present here today. Achieving this ambition will take a sustained and coordinated effort across government departments and state agencies. While doing so, we need to be responsive to people's needs and to the changing world in which we operate. For these reasons, policy making should not happen in a vacuum, nor can it be achieved through individual effort alone. It takes teamwork and collaboration, and as a whole of government policy, sharing the vision and events like this one today provide the basis for achieving that spirit of partnership. As we develop our services, we must continue to focus on achieving the highest standards, not just in terms of service provision, but also by promoting good mental health, reducing the stigma that exists around mental health difficulties, and investing in prevention and recovery. Engaging the wider public in a conversation about mental health is also vital, and I look forward to the imminent launch of the Mental Health Promotion Plan. It will complement the positive work already being done by the HSE. As you all know, mental health is inseparable from other aspects of people's lives and the society we live in. It affects employment, education, and physical health, and can intersect with homelessness, addiction, and the law. For these reasons, focusing on investment in mental health, including our youth services, will continue to be of the utmost importance. The goals of sharing the vision also closely align with those of Sláinte Care, which aims to enhance mental health services in our community. In the context of a significant restructuring of the HSE, I know a lot of consideration has been given to this by the leadership of the executive. Equally, it's important that we're cognizant of international best practice, and I'm really pleased to see the involvement of international colleagues in today's event. Involving outside perspectives and maintaining open dialogue can only ever enrich and improve the work we do. Finally, my thanks to Minister Mary Butler and the organisers for asking me to be part of what I'm sure will be a great event. Significant improvements have already been made, budgets and staffing substantially increased, and new facilities built and opened. And I look forward to the next 4 years of implementing sharing the vision under a new steering committee. So I wish you all the very best of luck with today's conference and a healthy and prosperous 2024 to you all.
So thank you to Taoiseach for those words, and also thank you to the Minister for her words. My grandson comes home from school every day, and I pick him up 2 days a week, and every day in his school they do a yay of the day. And sometimes he gets it the odd time, not very often, and it might be for being kind to someone or whatever it is. But I think when somebody comes in and says that they have managed to raise a further 10 million to support the work here, Minister, you get our yay of the day. So both the Minister and Taoiseach have mentioned the importance of international perspectives, and we really are delighted to have two excellent keynote speakers. I'm going to invite our first international speaker to join us now on the platform. Dr Ledia Lazeri is the Regional Advisor for Mental Health at the World Health Organization Regional Office for Europe since May of 2021. A native of Albania, she trained and worked as a psychiatrist there, working on the national reform of mental health policy and services. She's also led a large EU-funded World Health Organization project on improving services for people with disabilities. In her function as regional advisor, Dr Lazeri leads a team that brings together expertise across a number of policy areas: policy and services, rights and advocacy, communication and promotion in mental health. I want to ask her to address us and thank her very much for travelling to be with us today. Dr Lazeri, the floor is yours.
Honourable Minister Butler, dear colleagues of the Department of Health, dear David, colleagues from Ireland, mental health professionals, people who use the services, people who advocate for the services. It is with great humility that I am here in front of you today for two very good reasons. One is because about 20 years ago, while working in my home country, Albania, to reform the mental health policy and services there, my country got financial support from the Irish Aid, and through the Health Service Executive, we were able to mobilize a number of Irish experts, mental health professionals, but also service users who visited my country several times and were able to deliver hands-on support in the development of a particular network of services, including an acute inpatient service, daycare center, community mental health center, and the first supported accommodation for men and women in the country. And that was 20 years ago, and I regret to not have been able to join any of the teams that came for study visits in Ireland at the time. So it was with great trepidation that I took the flight and arrived to Ireland this Sunday, and I can assure you I took all the measures not to get COVID or flu, because I didn't want to embarrass myself and say, sorry, I again cannot come to Ireland. So this is one of the reasons, and the second reason is because, as you'll see in my presentation, Ireland and all the things that you are doing here are so much aligned with what WHO is trying to do with all its member states in the European region, that I'm truly humble of coming to present before you what we're trying to do. I actually hope that at the end of today, and at the end, as I could also see from the discussions yesterday with the Department of Health, that we have in Ireland a very strong supporter of our mental health actions in Europe. So before before going with my presentation, I want to remind you that the WHO European region is a region of 53 member states. So it is a geopolitically very, very diverse region. It has both EU and non-EU member states. It has countries that are as advanced in their forward thinking as Ireland, but also countries that are still struggling with a legacy of solid institutional asylum type care, and that are still that have still to start any action in reforming their services. And therefore, the cross-learning within the countries of our region is of primary importance, and that's why Ireland is for us a precious partner. So I'll start by reminding those that, like me, have been around for some time in exchanging with WHO, that in the year 2001, WHO published its first World Health Report dedicated to mental health. And basically, what was the main conclusion that the report, after describing what is the situation worldwide, the report more than 20 years ago said effective solutions for mental health disorders are available. And then last year, WHO published another report, the World Mental Health Report of the year 2022. And if you try to understand what has happened and what has changed, in the middle, in the 21 years in between the two reports, a lot of things have changed, but a lot of things haven't, or haven't improved. And what has not changed is the prevalence of mental disorders that is still, in the WHO European region, is at 14%, 1 in 7 people. What hasn't changed is the social and economic burden caused by such conditions that account to about 5% of dailies of disability-adjusted life years, as per the Global Burden of Disease in 2019. What hasn't changed is the number of people who actually receive treatment. For example, only about 1 in 4 people with psychosis are still not served by mental health services. And I can remind you that that means that in especially the eastern part of the WHO European region, this number is far higher, considering the difference also in the service availability and access. What has not changed, and has actually gotten worse, is the number of people who, of mental health workforce that has dropped from about 50 to about 45 workers per 100,000 people. And when we say workers, we include psychiatrists, nurses, social workers, psychologists, occupational therapists, and everybody that is recognized as a professional profile in primary health care physicians, so that deliver any sort of mental health care. What hasn't changed, but not for Ireland, as we heard from Minister Butler just now, what hasn't changed is the budget share that still is majorly allocated to mental asylums across the WHO European region, even though government expenditure on mental health has more than doubled between 2017 and 2020. So, and that is a very concerning figure, because it means that while advocacy efforts to increase investment in mental health have improved, what hasn't improved is the thinking behind how you use the money. So actually, before WHO advocates for governments to spend more in mental health, the call is to spend better. And Minister Butler, you just made the case now. You told us that in addition to the 80 million plus that you announced at the end of last year, you are just receiving another 10 million to be spent in areas such as young people, mental health, and so on and so forth. So just making the argument, well, your announcement today makes the argument why it's important not only to invest more, but actually to invest better. And what hasn't changed is the stigma that leads to direct suffering. And as per the Lancet Commission on Ending Stigma and Discrimination in Mental Health, people who live with a mental health condition state that stigma causes a bigger suffering, even bigger than the living with a mental health condition itself. So that not only leads to direct suffering, but stigma also contributes to the continued underinvestment in mental health. Stigma is very likely, stigma and prejudices around mental health are very likely the reason why even governments that are spending more in mental health are not able to spend better. So how are we in WHO? What is the guiding light then for us in WHO? And we have two main documents. One on the right here is the Comprehensive Mental Health Action Plan. That is a document that has been designed by and is under the responsibility of our colleagues in WHO headquarters in Geneva. So it's a document that pertains the global mental health audiences around the world. But then in Europe, we have developed the European Framework for Action on Mental Health, 2021-2025. I'll talk about that in a minute, and I hope you will see how that document is very much in line with sharing the vision, and why I will leave Ireland today with the hope that with this synergy, we can work more with each other. So in order to implement the European Framework for Action on Mental Health, WHO departs from one premise. And the premise is that efforts to make things better in mental health have been there before. So we cannot blame lack of understanding and lack of commitment from certain actors. What we can very clearly realize is that we still do not have a sufficiently large and critical mass of reform-minded people across the region that can put the necessary pressure while doing advocacy for things to change. And under this premise, WHO lobbied and worked for establishing what we call the Pan-European Mental Health Coalition. We call it Pan-European because we are aware about the divide between East and West, between North and South in our WHO European region. So it's Pan-European because we want to bring together all those realities, despite how much advanced or how little advanced those realities are. The importance of cross-learning is there. And it's also, the word pan means also that mental health professionals and policymakers are not the only ones that have a say. Persons with lived experience, mental health advocates, and as importantly, people from other sectors such as finance, such as education, such as police, such as justice, are as important into making the decisions and implementing those decisions in the long run. In that, the Pan-European Mental Health Coalition is kind of inspired by the WHO European Programme of Work, which mantra is United Action for Better Health in Europe. And you can see united from a very generous perspective. It's united in terms of member states united. It's united in terms of professionals and persons with lived experience. It's united in terms of health and social and finance and justice and sports and education. So united in a very broad perspective, but without that, we cannot have better health in Europe because the determinants of health are not only going away, we have more and more determinants of health, such as, for instance, wars in Europe. Who would have thought 3 years ago that we would have had 3 active war zones in our region? Who would have thought that climate change would be so accelerated that its mental health impacts would be felt already in our lifetime? So unless we are united, we are not getting anywhere. In short, there are 3 pillars for the European Framework for Action on Mental Health. The first pillar, I'm not going into details for that, but the first pillar is mental health service transformation, is the one on your left. In the middle is mental health in emergencies, or otherwise we call it integration of mental health into emergency preparedness, response and recovery. And that is valid not only because of the wars that we are experiencing, that is valid because of COVID. Minister Butler said that you were able to maintain 85% of your services during COVID, and this is again not a given, Minister. During the WHO survey during COVID times about the disruption of mental health services, we saw that 39% of our countries had severe disruptions of mental health services. So kudos to Ireland for maintaining that level of access to mental health services. And the third pillar on the right is ensuring healthy lives and well-being for all at all age, which means mental health across the life course. And there, Minister, you come again with your portfolio as Minister for the older age care. Now, I mentioned the Pan-European Mental Health Coalition, and we see it as an implementation mechanism, because one thing about WHO that not everybody is aware, WHO, it's a small organization. It has probably a big name, but we are our team, our mental health team in WHO Europe is far smaller than the mental health unit in the Republic of Ireland. So unless we have partners and allies across our member states, we'll not be able to implement anything. So that's why the Pan-European Mental Health Coalition is an implementation mechanism for the vision of that mental health framework. And then the coalition acknowledges the need for more diverse stakeholders around the table. As the former WHO Director General, Dr. Margaret Chan, some of you may be aware, she was the previous DG before Dr. Tedros. She always said, if you are not around the table, you are on the table. And that is for me a very, very good principle in working with partners that need to be around the table. Otherwise, finance is not around the table, finance is eaten. No one will talk about finance. Sports and education is not around the table when we talk about mental health. Those are eaten. People with lived experience are not around the table. Then it's again a topic that will be eaten and washed out of the discussions. So the coalition also serves as a structure for exchange between diverse members with shared interest in driving change. And those shared interests may be a professional interest, it might be a personal interest, it might be a funding resource interest. I have the resources, I want to invest. So the interest might be very different. It's a platform for peer learning and networking, and it allows coordination of advocacy efforts among coalition members. So then within the coalition, we had a consultation in early 2022 about what would the coalition want to have as priorities, because mental health is a world on its own, but we are aware about how feasible working on everything is, and therefore we had an extensive consultation, and we reached, informed by the members, the agreement that those are the themes to work on and to prioritize, that, as you see, are leadership and anti-stigma, mental health and well-being of children, adolescents and youth, mental health and well-being of older adults, and I look at you, Minister Butler, to see if we can extend more collaboration on that, mental health and well-being at workplaces, mental health in emergencies, and mental health service transformation. And I'm happy to say here that there is virtually no one of these working packages that we do not have an exchange and active contribution from Irish partners, be those government or or civil society actors. The membership, as you see, starts from member states' representatives. Philip Dodd, a salute to you. You are our Irish nominee for the coalition. But then non-state actors, and I see John Saunders and Catherine Brogan. Then advocacy organizations, again, the organizations you represent. People with lived experience. Professional associations, such as, for instance, European Psychiatric Association. WHO collaborating centers like the one in Cork, led by Professor Ella Arensman. Researchers, clinicians, international organizations, and private sector. We had the first meeting, it was still COVID, so you see us maintaining a very respectful distance, so that's why this picture is very static. But nonetheless, it was an exclusively online meeting. So the first meeting informed about the coalition goals. It started the development of working packages, and it facilitated networking among members. But first and foremost, what the first meeting said, enough with words, let's move from debate to action. We do not need to spend more time in convincing each other. We don't need to preach to the converted. We need to start acting. And this is what we have been trying to do since. This is the meeting of the coalition in Ankara, Turkey, where we had a very nice presence from the Irish colleagues. And in addition to that, we also are trying to capture the particularities of our sub-regions. For instance, we went to Central Asia, and there are 5 countries in Central Asia, starting from Turkmenistan, Uzbekistan, Kyrgyzstan, Tajikistan, and Kazakhstan. And those are the countries that have a legacy of the Soviet psychiatry that is very much delivered through the asylums, through mental asylums. So this is one of the areas where it is very difficult to penetrate, not only because of that legacy, but also because of the language barriers. So those are not countries that you easily can parachute consultants from Western Europe, because there is the language proficiency is low. So what we did was to have a policy dialogue dedicated to that, and I was very moved. The woman, the 2 ladies that you see on that picture there, the one on the right is a lady that ended up in a mental institution when she was diagnosed with a mental health condition. She was meant to be there for life. She was stripped of every right. She was stripped of the right to her family, of the right to education, of the right to employment, of the right to accommodation when she was sent to the hospital. But then the other lady, she is the mother of a child with a learning disability. She set up a small NGO at a country where civil society is not the norm. So she did a tremendous efforts to start this project that is bringing people out. And actually, the lady on the right could then benefit from that project and get out of the mental asylum and start slowly to be reintegrated into the daily life. Still with a lot of difficulties, because employment policies are not there to support her getting employment, because accommodation is not there to support her getting accommodation. So she still relies on charity work. But this is the first swallow of a long series of actions that need to take place for mental health care in that part of the world, moving from asylum-based to community-based. Under the mental health leadership package, we are together with King's College London and with, as a co-creation with persons with lived experience, we are developing an anti-stigma toolkit aiming to launch later this year and at the 2 years anniversary of the Lancet Commission on Ending Stigma and Discrimination. And with the Global Leadership Exchange, the former international initiative for mental health leadership, we are developing a curriculum that is soon to be piloted on as a mental health leadership course. When it comes to mental health and well-being of children, adolescents and youth, there are a number of people in this room that have attended our different activities to develop quality of care tools for mental health care of children and adolescents. We are also conducting some country analysis, developing a country analysis tool together with UNICEF, and as a first of its own in its right, we have co-designed a framework for not me, but the young people with lived experience that we engaged with were able to design a framework for youth participation and engagement. When it comes to mental health and well-being of older adults, this is the area where we have worked less, I should say. There is not a big uptake of this particular area among our member states, so it is very heartening that Ireland has a minister dedicated to older adults, and therefore I hope that after this we can also add mental health for the older adults in the agenda of our bilateral collaboration with Ireland for kind of bringing this experience elsewhere. When it comes to mental health in emergencies, very briefly, as I mentioned, when we instituted this working package, COVID-19 was the biggest tragedy that this region had seen at the time. And since then, we then had the Russian invasion to Ukraine, so that's a permanent emergency where mental health of the veterans, of the population, of children are becoming more and more acute, and where we, together with our colleagues within Ukraine, both at the Ministry of Health but also in WHO, we are trying to design not only small services provision but also policy frameworks that allow improvement of services on the long run. We are also working with Armenia and Azerbaijan to support the displaced people that left Azerbaijan towards Armenia. And then, of course, we are working with, in the aftermath of the earthquake in Turkey and Syria. The latest development is the conflict between Israel and Hamas. And because Israel is a member state of the WHO European region, we are also engaging with Israel to see what is the need, the mental health need of the internally displaced people within Israel. And then our colleagues in the other region are working for the needs of the Palestinians in Gaza. When it comes to mental health service transformation, I'm happy also to report to you that together with the Royal College of Surgeons in Ireland, we are mapping the European mental health workforce and the regulatory frameworks, and then we are working hopefully within spring this year together with Department of Health here to pave the way towards the development of a roadmap for digital mental health in Europe. So again, Ireland is taking a role into into fostering those international developments. And then in terms of cross-fertilization, we are also having study visits from various countries. I mentioned Trieste here, but we are having a study visit to Ukraine. More study visits have happened previously in Belgium. And of course, based on my experience 20 years ago, I hope Ireland can also accommodate some study visits from the countries that need it in the near future. Now, for the sake of time, I'm not going to the tools because this is a very brief overview of the tools that WHO uses or introduces for mental health services evaluation and transformation on human rights and standards of care, on peer support services, on advocacy and civil society. I'm stopping here on the guidance on community mental health services and its 7 technical packages. But of course, all those guidances, as you know, WHO being a member state organization, our guidances do not hang in thin air. Our guidances are based on the good practices that are put forward by our member states. So what happens in Ireland, for instance, is something that we are very much looking into understanding, exploring more, but also sharing more with other countries. Last but not least is the WHO collaboration with the European Commission. We have been asked by the European Commission to support the 27 EU member states plus Norway and Iceland to address mental health challenges as part of the flagship one of the EU's comprehensive strategy on mental health. And what we are trying to do is some evidence building through surveys, through regional surveys, capacity building through the WHO signature tools such as quality rights, MHGAP, community guidance, etc., and policy discussions and dialogues with member states on mental health strategies, frameworks, and actions. And my last slide is, we cannot do it alone. Again, drawing your attention on the fact that WHO is not this big organization that has hundreds of people working for building evidence, for going to implement, for developing policies. We are a member states organization. We are as good as our member states are. So please do allow us to use your expertise and the strength of your convening power into more work for WHO in the European region, and join us and help us in bringing mental health out of the shadows. With this, another warm thanks to all Irish politicians, Irish policymakers and implementers, Irish mental health professionals, persons with lived experience, advocacy organizations for the great collaborations with WHO. Thank you.
Thank you so much, Dr. Lazeri, for that really interesting presentation, that overview. Excuse me, and one of the very heartening things are the number of interactions between Ireland and the other partners. I think that's very heartening to hear from you this morning. And also, I think some of the challenges there, you know, the numbers receiving treatment, the numbers not receiving treatment. So there are still gaps there. And I liked your phrase about spending better. And in some ways, that is, I think, one of the challenges that we face. So thank you so much for that. I'm going to move on to our next panel now, if I might. Really, this panel is about reflecting on the first term of the National Implementation and Monitoring Committee. I'm going to introduce the chair of this panel to you. And then I'm also going to introduce John Saunders, who has already been mentioned. John is the outgoing chair. So Ian is going to take the panel and take you through the panellists. Ian is known to many of you. He is the Chief Executive Officer of Spun Out, Ireland's youth information and support platform, working towards an Ireland where all young people are empowered and supported to thrive. Ian is also adjunct associate professor at UCD School of Psychology and is a member of NIMC. We're delighted that he's going to chair the panel. He was also a member of the National task force on youth mental health. But before Ian takes over the panel chair, I want to introduce John Saunders, who, as I say, has been mentioned. And John is the Executive Director of UFAMI, an organisation of family member associations across Europe. He was the Chief Executive of SHINE, supporting people affected by mental ill health from 2001 until 2021. So he brings a huge amount of experience, and as I say, he's the outgoing chair. And we're just going to hear some reflections from John as we look back at this part this morning, and we'll be looking to the future. But really delighted, and again to thank John for the work he has done and to hear from him in the first instance. Thank you, John.
Good morning. Thank you, Grania. It's great to be here, and it's great to see so many people who have been involved and will be involved in the ongoing implementation process. As Grania said, my role is to reflect, and I'm going to hopefully not repeat too much, but I suppose the starting point for me was just to think through what were the important aspects in terms of implementation of any policy, not particularly mental health or indeed health policy. It seems to me that the primary issues are, first of all, the need for clarity of objectives and purpose. And I think that's very clearly set out in sharing the vision. I also felt strongly at the time that there needed to be sincere buy-in and ownership of the policy by all of the implementers, and in this case, as you know, the implementers are primarily the providers of services, the HSE, but also significantly the government departments that have a function in terms of some aspect of sharing the vision, or indeed of mental health care and policy across the land. I think it was also important to note that leadership of the strategic and operational levels was important, so it wasn't just about the CEO and the senior managers, but about all of the people who are providing services and providing programs and heading up various projects across the land, and indeed in every aspect of the country. So sharing the vision is an all-Ireland 26 county policy and needs to be implemented across all counties of Ireland. I think there needs to be an adherence to the underlying principles and values that are in sharing the vision, and particularly, this is a job I think for the next couple of years, we need to be able to articulate and demonstrate clearly that the values and the principles which are very clearly written in sharing the vision are seen on the ground, that we can see them, that we can measure them, that we can acknowledge that they exist there underlying all service provision. I think there's an important fundamental aspect of policy change is an understanding of and a willingness to change. We know that large organisations, by definition, find it difficult to change. And there certainly needs to be, not just among the leadership, but among those who operate services, of the need to bring about change for the better, and in this case in terms of mental health care and mental health and well-being across the country. Sufficient resources are important, obviously. We've heard from the Minister about the budgetary situations and the additional funding and so on, which is really, really welcome. I think we need to, I suppose, stand firm that even in times when there is budgetary difficulties for whatever reason, that we still commit to policy implementation. There's no doubt that budgetary constraints may slow down process, but it shouldn't stop process. And we think we have to keep going to make sure that implementation occurs. I think there needs to be an accurate measurement and recording of progress. And that, again, is written into the policy and has been clearly articulated in the implementation plan and in the reports of the group so far. That last one here, accurate measurement of the impact of policy, is particularly important. Sharing the vision has a very clear commitment to measuring what's called outcomes. In other words, what is the impact, what is the benefit or otherwise of a change or of a new service on the people who receive that. So that's really, really important. And it's a little bit different to outputs, which is about essentially a quantitative analysis of what service is being provided. So the experience, and Minister Butler got ahead of me on this, certainly at the start of the NIMC 3 years ago plus, there was a lot of discussion, not just within NIMC, but around the country generally, about what is sharing the vision in relation to the previous vision for change. Is it a new policy? Is it a continuation? Is it a son of? What is it? And I heard all sorts of language being used, like it's a refreshment, it's a continuation, and so on and so forth. There was a lot of time, I think, spent thinking that out, not just in the policy world, but in the implementation world as well, to try and figure out and to reconfigure or structure sharing the vision in line with vision for change, which was the previous policy. I think what's obviously different about sharing the vision is that it has that process of continuity from, at the one end, managing and responding to people with very, very severe mental ill health, and at the other end, looking at the population and demographics around mental health and well-being and how you support the population generally around those issues. So I think there was a stasis at the start, but we quickly got over ourselves there and decided that we just had to get on with implementing what was on in the policy in terms of the document itself. As has been acknowledged, COVID-19 stepped in and certainly slowed up the process and caused general confusion and mayhem for a while. But again, like the rest of the world, we adapted very quickly and got on. I'm positive that COVID's presence and the focus on public health took away some of the energy around early implementation of sharing the vision. Likewise, the attacks, the cyber attacks on the HSE and the Department of Health undoubtedly had some effect on diverting attention for a short period of time. I think one of the things that stands out for me looking back on it is that there was from day one very, very strong and very, very coherent communication and collaboration between the NIMC, which was charged with oversight, and the implementers, which is primarily, of course, the HSE, as I said, and also the other relevant government departments. And I think that process of communication and collaboration and discussion and dialogue is essential to implementation. There's no point in a NIMC sitting in a closed room analysing data and not referring to the realities of what's going on around it in terms of implementation. And the people who know about implementation are the implementers, the people out there charged with delivering a service, an existing service, or indeed changing a service or creating a new service. I think in terms of the structures, and I don't want to bore you with the detail, but there was a very positive, comprehensive structure set up within the HSE, primarily called the HIG, the HSE Implementation Group, led by Derek, who's here somewhere. I don't want to embarrass you, Derek, but thank you very much for leading a very strong, coherent team who spent a lot of time looking at how sharing the vision was working in their own particular sector and feeding back the information that was required according to the implementation plan and to the recommendations set out in the policy. I think that was a very positive starting point, and it ensured what I was talking about earlier about buy-in and getting ownership of the policy across the entire structure, not just in one particular office or one level of leadership. I think recruitment is obviously an issue, and we all know about it, so there's no point in me telling you, but the various reports for the last 3 years have highlighted the need to focus on adequate recruitment to make sure that we had the right people in the right place at the right time, to borrow a well-worn cliche. The HSE were very quick to point out, and rightly so, that they have a major problem in terms of attracting staff into the system. They have inherently create problems in terms of promotion and movement of staff within the system, because every time you promote and move somebody, you create a vacancy somewhere else. There's problems of retention in terms of graduates. There are problems of people emigrating abroad for all sorts of reasons and so on and so forth. And we've been constantly saying to, not so much the HSE because they can only do so much, but to government, to the Minister, and I've constantly said it to the Minister and her department, that there needs to be a very strong, proactive approach to additional numbers of graduates in terms of the core issues, the core services, and the primarily psychiatry, medical psychiatry, mental health, nursing, and psychology, clinical psychology and mental health, and perhaps some other areas as well. But in order to deal with the issue down the road, we need to have more graduates coming out and more graduates staying here. We also, I suppose, need to attract people back. That's a very unreliable system. Trying to attract people back, it's very hard to quantify that and know how many people are going to come back to you from abroad. So that recruitment issue is always an issue. I know it's an issue elsewhere as well, but I'm not concerned with elsewhere. So, in terms of Ireland, we need to ensure that we have the people there to provide a policy which has been funded and developed and put in place. I think there's a need, again, with any large organisation, there's a culture and a structure to that organisation. And culture and structure is developed to suit the organisation, and that's the way it is. But I think there's a strong need for everyone to realise that culture needs to shift as well. Yeah, and culture is how we do things. That's essentially what it is. People need to think carefully about how they've been doing things and how they should do things in the future in respect of policy change and policy improvement. So it's really one for all of us to embrace that change and to go with it, even though it hurts. Change, nobody likes change. It does hurt some people, but it's important in terms of making sure that we get to a place where we have a new and presumably and hopefully a better policy and service in place. I think we have to acknowledge, and certainly I was trying to do that with NIMC, that there's always a tension between the ideal, the policy, the written document that's been worked on for many years and has inputs from international and national experience and research and academia and so on. There's a natural tension between that position and the reality, the real world of what happens every day in Ireland in terms of our primary care and its ability to respond to people with mental health difficulties, the specialist mental health services and how they respond to the various presentations that they have, the issues of recruitment, the issues of buildings, and so on and so forth. There's a long list of issues that are real issues in terms of mental health care services. And I suppose at this level, what we need to do in the first place is acknowledge that tension, acknowledge that contradiction sometimes, and address it rather than just ignoring it or hoping it will go away. I think the other thing about sharing the vision, which has already been mentioned, is how it seeks to involve the persons who use our services, people with mental health difficulties, mental illnesses, call it what you wish, and their family members, the people that come looking for support and service. It's very important, as the division says, that those people are involved in every aspect of planning and development. And I'm very proud of the fact that NIMC managed to create what's now called the reference group as a tangible, practical way of seeking the input from people who have had the lived experience, not just of mental health or mental ill health, but the lived experience of using services, which is more important, I suppose, in one respect. The reference group is not in sharing division. What's in sharing division is a very large amount of reference to the importance of the user. What I think the reference group is trying to do is demonstrate that in practice. And I'm delighted that it is alive and well. We have some members here and chairs here as well, you'll hear from later. I'm delighted that it's alive and well, that it has survived the first 3 years. It's 2 years, because it was created at the end of year one, I think, of the NIMC. It is due for renewal next year, and I am hopeful and certain that it's an important element in terms of going forward. And the reference group may be shaped and improved in the future, but it needs to be there, not necessarily to represent the entire country of users, which it cannot do, but to be representative of and to give a real input into the benefits or otherwise of particular policy practices and policy implementation. So it's a really strong, I suppose, focus of the real influencing the ideal in that context. So I'm delighted that it's there, and thank you very much for all the hard work. It's a huge amount of hard work going on for a group of people who are volunteers, who have day jobs and night jobs and all sorts of other commitments. So I think hats off to everybody in the reference group for their great work, and to the chair and the leadership of that. So that's my closing points. I think, Ian, you're going to come up and take over and do a chair. So thank you very much for your attention.
Brilliant stuff. Thanks, John, very much for that perspective. Great stuff. Thanks, Oisin. I'm going to invite Siobhan McHale, and also Dr. Amir Niazi up to join us. So that's been a really helpful overview, I think, John. I think our purpose as this panel is to reflect on implementation monitoring for the first 3 years of what is a 10-year strategy. We're a third of the way through almost. And so really kind of, I guess, representing our many dedicated colleagues who were with us on the National Implementation Monitoring Committee, and also everybody in this room who has played a part in the implementation of Sharing the Vision over the last 3 years. So just to introduce my colleagues, my first panellist beside John is Siobhan McCardle. She's Assistant Secretary and Head of the Social Care, Mental Health, Drugs Policy and Unscheduled Care Division at the Department of Health. A wide brief, as I think the Minister referenced earlier. And prior to working in the department, Siobhan worked in a variety of senior roles in the HSC, including Assistant National Director for COVID-19 Operations, which I'm sure was a busy role, and is a qualified speech and language therapist by training. We also have Professor Siobhan McHale, who's worked as a consultant liaison psychiatrist for over 25 years and been in her current post in Beaumont Hospital since 2006. She's an associate clinical professor in the Royal College of Surgeons of Ireland and has many fellowships to her name. She's also previously chaired the National Clinical Programme in the management of self-harm, and was appointed to the college as the College of Psychiatrists representative on NIMC, and ably chaired the NIMC's Women's Specialist Mental Health Group. So we'll be talking a little bit, I think, about your perspective from that work as well, Siobhan. And finally, but by no means least, Dr. Amir Niazi, who is the current National Clinic Advisor and Group Clinical Lead for Mental Health, having previously been the Executive Clinical Director in the Louth Meath area of CHON since March 2012. He's a General Adult Consultant Psychiatrist and a member of the College of Psychiatrists of Ireland and the Royal College of Psychiatrists in London. So I wanted to barrel through those introductions because we have a lot to talk about, and we've got limited time to do it in terms of reflecting on the first 3 years of implementation monitoring. Siobhan, I might start with you, Siobhan McCardle. Kind of, when the department and when the Minister was establishing the NIMC, kind of what were the hopes of the department in terms of what it might achieve in its entirety, but also in its first term?
I think the Minister summed it up in terms of the department and across all government departments, very strong in delivering and designing policy, but what often can happen is the policy gets published and it's put on a shelf. And I think it was really important from the department's point of view to be able to see implementation, to see the policy being delivered and to learn what that meant. And why that's important is because it makes a difference to people's lives, but it also shows and helps us learn what's working well and maybe what's not working well. And back to the Minister's opening comments about how to attract further funding and investment. And the best way to do that for mental health services or for any part of our health service is to be able to demonstrate that it works and it has an impact. And I think that's what has been the strength of this particular structure, the implementation structure, is about focusing on learning, on implementation, and also not on it just being within a narrow focus of health service particularly, or specialist services, but that broader range, our NGO sector, our wider society, and the roles, very clear actions and roles for very many different actors. So 100 recommendations to deliver. So fairly ambitious, and the only way to do that is to have that level of accountability and oversight. So that was what was important to the department. And I think the breaking it up into, it's a 10-year policy, so very ambitious and very hard to see 10 years in advance. So having it broken down into smaller sections allows us to pause and reflect and consider what has worked well and consider the wider context in which we're delivering health services as well. So, for instance, the impact of new challenges over the last number of years, the learning from that, changes in digital health and the focus that will have, the impact of recruitment and staffing and considering different ways of working. So it allows us then to reflect and consider then to have real tangible deliverables for the next period of time.
Yeah, we might come back to some of those challenges in a moment. John, you've very helpfully kind of provided an overview, but you had some experience coming to this. You chaired an implementation monitoring body for Vision for Change from 2009 to 2012. What was front of mind in your thought process around how you approached kind of taking on the role of independent chair of NIMC for its first term?
Well, I did experience the previous monitoring. Myself and Ruth Barrington was the first chair of the first monitoring group way back in 2006. And that floundered, I think, primarily because the country went into chaos in terms of the economic downturn and all the stuff that went on. And let's face it, in those two monitoring groups, there was very little to be reported about positive improvement in terms of policy at the time. This time around, I felt sharing the vision itself, the document was much more grounded in the practicalities, even though it's quite an idealistic document, as it should be, but it was quite grounded in terms of what could be achieved and what was required by the people using the system, primarily in the secondary services, but also in primary care and in mental health and welfare. Mental health and well-being. One of the things that really attracted me, and I didn't mention it in my speech, but the idea that a significant number of the NIMC membership are actually people who are presumably lead implementers in the HSE, and there was 4 people on the old NIMC, and there's a number of people on the new NIMC who are charged with implementation. That, I think, was a positive, because there were people who brought the reality to the table that I was talking about, but we were talking about the ideals, so they were leaving with some sense of a mix between the ideal and the real. And hopefully, I do think, actually, looking back on it, it's better that they were involved in that NIMC group. I'm delighted to see that the second NIMC has a number of people in that position as well. I think that's a positive that stood out for me at the time.
Yeah, the continuity is really important. And to that end, Siobhan, as an outgoing member of NIMC and somebody who works on the front line, one of the things that I most enjoyed about our first term was that practical perspective that members brought, including yourself. Kind of, has NIMC and its structures associated kind of brought to bear kind of value in supporting the implementation of a national mental health policy from your perspective?
It's been a great honour to be involved in NIMC as a person who works clinically. It's been nice to be involved in that interface between policy development, how things are laid out, and then how this has actually been achieved on the ground. And there have been occasions where we've used clinical examples in meetings to kind of cross-check with ourselves. Are we moving the deck chairs on the deck of the Titanic, or are we actually making real change? And that constant tension between the aspirational and the reality of what we're aiming to achieve. I think the nice thing about being involved with NIMC and sharing the vision is the ability to look at translating practically the changes that are very much required. I think we've made, and through the support of government, really positive changes with regard to resourcing. The focus up to now has been largely about we need more resources, we need more resources. I think now moving that discussion to how do we achieve the best efficacy and efficiencies with the resources we have, knowing the changes we really need to make, and taking that from an evidence-based point of view, but also taking leaps of faith also in terms of new developments rather than repeating the same challenges, I think, over time.
Yeah. 100%. And we might come to speak a little bit more about your work in the specialist group around women's mental health shortly. But first, Dr. Niazi, kind of, I'd love to hear, we're going to focus on the challenges shortly, but from your perspective, kind of, what has been some of the kind of main achievements in the first kind of term of implementation of sharing the vision? Kind of, from your perspective, where is progress really being made?
Thanks, Ian, and thanks the opportunity even to be among all these colleagues. First of all, Minister, thank you for the additional funding that you have secured. I know, like, you have been helping us all along to achieve all these goals that we are trying to do. I think even having an implementation plan was a success. Like, we have, I think most of clinicians here have lived the times of when the original policy came, Vision for Change. And I think what was missing there was an implementation plan. So even having an implementation plan in my head was a start of a success story. And in the 3 years, like having 100 recommendations, going through all of those COVID and all of those challenges that we had, and I think like the team that I had, they were so dedicated to make sure that we achieve some of those targets. And seeing that we have almost completed those short-term targets that we set for ourselves and nearly achieving them, like we saw the buzz in the room that we are doing something good for our patients, for our service users, for our families. So I thought participating and being part of that story for me was a huge success.
Yeah, and just I think one of my reflections is that there's been a huge level and variety of activity happening as part of the HC implementation group, but in terms of all the specialist groups, there's been lots of dedicated folks involved in kind of teasing out some of the recommendations. It's very easy in some senses to write a policy and say, you know, I'm thinking of, for example, recommendation 36 around the transitions from CAMS to AMS and extending services up to 25, but actually operationalizing that is a huge challenge. And so there's been countless colleagues involved in trying to tease that out. And as you say, Siobhan, bringing that frontline perspective to it as well. I guess kind of focusing perhaps maybe on that recruitment piece and that workforce widening element, Siobhan, you mentioned that as one of the challenges. For me, I think that's probably the greatest challenge to implementing sharing the vision. What's happened over the last 3 years to try to address kind of the challenges that we're facing in that space?
So the sharing the vision and mental health policy sits as one of a number of policies in the department. So there's a really strong focus on having a strategic workforce plan for our healthcare service across the service. So we work very closely, and I know colleagues who are involved in NIMC are working very closely with the workforce colleagues within the department and our other government departments with responsibility for training in order to identify what will the workforce look like, what's our workforce requirements for now and into the future aligned to that strategic plan, and what kind of skill set do people need. So that's a focus on both training our existing workforce to adapt and to change and to deliver differently with what we have, but also, as John pointed out, the need to increase certain numbers of colleagues, of training places for medical staff, for nursing staff and for other allied health professionals. What we have seen is an increase in undergraduate placements across a number of key areas of staff that will be involved and will come into our services, including mental health services. We've seen a new consultant contract come on board aligned to Sláinte Care, and Sláinte Care being the national policy, which is about moving our healthcare into community and supporting the staff who want to work in community in different ways of working. And we've seen that already that's attracting an increased number of staff into our mental health services. So lots done, and the cliche going, lots more to do, but certainly working very closely with with NIMC has been really important, and also with the WHO. So our workforce, our strategic workforce colleagues in the department don't work on their own. They work very much in partnership with our European colleagues, and the challenges that we're experiencing in Ireland we're sharing with and also learning from our colleagues in other countries to determine how do we deliver and continue to deliver our mental health services with what we have and with the staff we have, supporting them and retaining them, and that's really important. We often think just about bringing in new staff. We have to ensure that the staff who work in our mental health services are well looked after, are, you know, come to work every day vibrant and motivated, as Amir was saying, and continue to bring that experience and expertise. And so that's really important about how we continue to retain our staff. So lots happening there, Ian.
Yeah, and I think, you know, one of the focuses in the first term, John, has been that, you know, we need workforce to be able to deliver the aspirations of sharing the vision. You know, there's often a tension between who funds posts, who funds training posts, etc. I think one of the focuses of NIMC has been on that need for a whole of government approach to how we broaden the workforce. And the Minister mentioned as well peer support being a new element in sharing the vision. You know, where do you think we need to make progress in terms of both that whole of government approach and widening the concept of what the workforce looks like?
I think there's a number of issues that I suppose I knew already when I became chair, but it was put in focus for me the last couple of years. We have a huge NGO structure in Ireland, and across the spectrum of mental health, from mental health and well-being right down to provision of very specialist services. There's a whole range of organisations out there, you know, yourself, and they have a really important part in the policy provision and policy development and practice. And really we need to sort of harness that as much as we can and make sure the entire jigsaw works right, the statutory services plus the not adjunct but the NGO services that are in that particular arena, whether it's youth mental health or older people, whatever, it doesn't matter what it is, but the whole range of services out there, and they need to work coherently to provide the policy drive. I think the second thing, and again this goes back to recruitment, I think, and it's something we were very strong about from the early days, is to try and avoid pilots. Pilots by definition create a postal code service for somebody, and very often the policy history in Ireland has been about a pilot becoming a medium to long-term, never-ending pilot, and nothing else happens. Now, I suspect, and I'm open to criticism, that one of the reasons why we do pilots is that we don't have enough money to do the whole lot. So we concentrate on one region and see what it works. That's a fair point, and that comes back to the idea of recruitment and how you spend money, how you invest money. But the other side of it is that not most, but a lot of what's happening in mental health has been tried and proven elsewhere. We don't necessarily need pilots as a way of testing. And so there are examples where we just get on with it and try and provide a 26-county service as best we can. I know it's difficult, easy to say that, very hard to do it, but I think it's something the NIMC pushed in the first couple of years and hopefully will continue to push.
Yeah, I get the allergic reaction often when the word pilot is used in a room, particularly in NIMC. Professor McHale, you were chair of the Women's Mental Health Specialist Group, and you produced a really valuable document that I'd love you to speak a little bit more about. But also in doing so, I think the voices of lived experience, and John referenced it in his presentation, the importance of having the reference group available to NIMC to get and seek its guidance and views has been really, really important. I've seen it in the Youth Mental Health Transitions Group, you know, 1,000 young people with experience of CAMS, 250 who have experienced the transition between CAMS and adult services, having their voices reflected in that piece of work. Firstly, you know, kind of how was it for you leading a specialist group? And secondly, kind of what was the importance of that lived experience perspective to you in that work?
Well, I might approach those questions back to front because I really don't want to leave out the importance of the reference group. I think it was a key success story of the first 3 years of NIMC. The quality of work that the reference group, who did such a good job in terms of coming forward, in being interviewed and applying for this important, across a competitive process, and then to be able to produce such a quality of work that they're consistently bringing in a very collaborative manner, and that collaborative piece has evolved over time, and with communication and reaching into NIMC and reaching out into the reference group, and all that cross-collaboration work, I think, has led to, a transformative component of what's really at the heart of the Sharing the Vision policy. As chair of the Women's Mental Health Reference Group, I was tasked with a very specific job in terms of recommendation 3, which was in collaboration with the Department of Health and the Women's Health Task Force to produce a document within a 1-year period, ensuring that we were embedding women's mental health throughout Sharing the Vision. And some of the things that struck me within that and that are close to my own heart is that key piece of there's no health without mental health, that interface between health in its broader perspective. The risk can be in healthcare settings and mental health settings, and especially in the way it was before, we're now going to be developing the new regional health authorities, is more siloed areas of mental health and then the rest of health working alongside that. And what interested me in the work with the Women's Health Task Force, which I hope to continue in a collaborative way, is the cross-referencing and focus on, for example, trauma. There's been a lot of work done in terms of development of gynae centres, menopause-focused work in that. But that area of trauma hadn't actually been incorporated in those earlier initiatives, and ensuring that that's carried through in an integrated way so that we don't have, and to me the vision is ultimately moving away from concepts like physical health and mental health to where we're at a fully integrated health component. And I think the regional health authorities development will bring lots of opportunities, but I think also great challenges for how we progress and don't get lost as a mental health service within the broader area of health. And I think we'll need to be very thoughtful and very constructive and collegiate in how we approach this.
Siobhan McArdle, just before we go to the floor, I see some roving mics, so we're going to use that opportunity, given they're here, to take some questions from the floor in a second. But just one of the things I think we struggle with as a country is, you know, whole of government approaches, generally speaking, and implementing a policy like Sharing the Vision, which has, you know, named lead departments that are not the Department of Health. You know, from your perspective, how has working with those other departments gone in the first kind of term of implementation? You know, what kind of has the feedback and the reaction and the collaboration been from other agencies?
So it has been really positive, I think, and that's testament. The evidence of that is the fact that we have such good engagement from our partners across other government departments. I think it built on some work that was happening within Connecting for Life. So Connecting for Life, our suicide prevention and self-harm reduction plan, had created a platform of cross-governmental buy-in. So it was a whole of government policy, continues to be. And so we find the same government departments very much committed to the fact that mental health is everyone's responsibility, and that everyone, you can feel the energy in the room when people from the other government departments are there. Nobody is sort of sitting there thinking, oh, what are you doing over there in health? It's around having that engagement and discussion and taking the ideas and turning them into real actions within those government departments. I think the structure as well of the NIMC has helped us. I'm sure there are some colleagues around here, has helped us as we've developed other pieces of work cross-governmentally, and I'm thinking of the high-level task force that we have with our partners in the Department of Justice around looking and supporting people who come through the criminal justice system. And because we have that footprint and that way of working already with our partner government departments, we were very quickly able to move into an implementation space, and that can only improve outcomes for those people who access services across, you know, where we have to work in a joint way. So I think we have a lot of learning to do, and I think that's why I welcome the evaluation and the sort of the pause and looking forward in the next 4 years, and the feedback from other government departments to see whether that is working. And for those who receive services through those parts of society, is it having an impact? Is it felt way over there and not just in health? So I think we have a lot to learn. Thanks.
Absolutely. I'm going to come to each of you and ask you in a moment kind of what's the one thing that you feel you've learned or we've learned from the first term of NIMC, and what maybe is the one priority you would like to you know, share with the next term or the next 3 years. But first, I'd like to take maybe 2 questions from the floor. We take them both at the same time, just to get them answered as efficiently as possible. We've got one here, and have we got a second anywhere? We've one here, Stephanie, as well. So 2 on this side of the room. And if you just introduce yourself and where you're from as well, if that's okay.
My name is Marie Fahy. I'm a speech and language therapy manager working in Dublin, North City and County Cams. And my question really is for the outgoing chair, maybe more relevant to the incoming chair. Will speech and language therapists be included in the membership of NIMC? Because as you know, speech and language therapists work in 73 CAM centres, psychiatry, intensive care units, rehab psychiatry, general adult, even established infant mental health in North Dublin. Yet, I suppose, in the last 3 years, there's been no representation from IASLT. And I'm hoping, it says the title, Sharing the Vision, a Mental Health Policy for Everyone. Does that include speech and language therapists on the NIMC membership?
Great stuff, thank you for that. And Stephanie as well, we'll just grab your questions too, if that's okay.
Thank you very much, Stephanie Manahan from Pieta. Thank you for a super morning, by the way, and Minister, well done. We're delighted with your news. I suppose for me, and it's reflecting on, John, your comment there on the pilots and picking up on what Siobhan was saying about the regions and the opportunities, yet being mindful, because I'm very aware of one of the comments from Bernard Gloucester when he spoke last year about the move to the regions, that eventually the national system, the centre, will not be dictating to the regions how they will invest and how they will spend their funds, which is absolutely appropriate for regional needs. But that doesn't get away from some of the benefits of pilots that can be rolled out and learned nationally, and we can benefit nationally. So I suppose I'm just interested in how we're going to maybe work with that, so that we're not going to lose everything that we can actually gain from a regional success that could benefit nationally. Thanks.
Brilliant, thank you so much. Siobhan, McArdle, I might come to you first on the first question around representation, because I think it's probably the department who has the role in kind of setting out who the membership of NIMC is.
So it's a good question to a former speech and language therapist. So I have a bias in that way. However, I suppose the structure, the focus of the structure, the steering group, is to drive the implementation of the recommendations. There are a lot of substructures within that, and I'm delighted that that over the last 3 years, and particularly in the last 2 years, we've learned and we're appreciating the focus we need to have on youth mental health. And I think we've Donn here and Mandy in the room recognising that working with the HSE, that we're going to have a stronger focus on supporting, developing and enhancing our youth mental health. And that will be everything from early intervention, prevention, and all the way through to specialist services for young people. So what does that mean for the various disciplines or staff that work in that setting? It will be about having a voice within the structures or the substructures, and it's important that we're not designing it around the staff. I think, John, you had said that, and the Minister had said that the main critical element here is that we're designing around those who use our services and ensuring that that's at the centre. And then as we look at what those actions mean or recommendations, that we have the right people involved and the right voices and the right experience. And in terms of professions like psychology or speech and language therapy or OT or peer support workers, it's ensuring that the evidence that comes from those perspectives form and inform the plans that we're doing, and a particular focus on youth mental health. So thanks, Marie.
As the Chair, do you have any reflections on that representation?
Just 2 things. Sorry, I couldn't get your name. The lady from the SLT organisation. Yes, I'm aware. I think your organisation wrote to me earlier in the new NIMC, and we discussed with the department, and really the department was guiding it, because the department decides who is selected through the Minister, as it has done for the second NIMC. But I will make the point, it's an important point, that the people selected for any group like this are not necessarily representing a sector. Now, they are by definition, and it's inevitable, they are coming from professions, psychology, social work, etc., etc. But they're there to be representative of the services on the ground and to give energy and a voice and an expertise and a wisdom to the policy and the implementation of policy. So I never had an expectation, for example, over the last 3 years, that any member of NIMC would be reporting back to its sector or its specialism and would be bringing its specialist issues to the table. Now, they did, and that's fine, because we're humans, and you know, if I work in a particular sector, I have passion about that, and I might bring that to the table. But I was very careful to try and choreograph that as best I could and not end up responding to very specific issues that sectors had, because you're just chasing your tail forever on that. And I use the word choreograph. Sometimes people use, whiplashes, because you had to try and keep a group in order and keep them focused on what they had to do, which was to oversee implementation by a bigger organisation and by government departments. So I was less worried about that issue. I know you're concerned about it, and I respect that. But it was about taking a group of people whose wisdom, knowledge and expertise could give voice to the implementation and to report back on it, which is primary function of NIMC, by the way, reporting back. It doesn't implement, it reports back to government in the first instance.
Dr. Niazi and Professor McHale, I might come to you on Stephanie's question. So, we've seen the benefit of trialling things in different regions. We obviously see the implementation of the regional health authority or areas coming up shortly. What impact is that going to have from a policy implementation perspective, from both of your perspectives? I might start with you, Amir, first, if that's okay.
We are already... the area of my interest is clinical programs, and we are already aligning clinical programs with the regional health authorities and say how we deliver them. In relation to pilots, I'm somebody who fully supports pilots, because we do something which is very new, do a model of care for clinical programs. We learn from experience from internationally and everywhere, but instead of replicating in the whole country, doing few teams and learning from it, evaluating it, and then making some changes to see how we can improve it before replicating it around the country. So that's what we are definitely, the experience that I have. And I think in relation to RHAs, our focus will be again to make sure that when we are developing our services, it's for every part of the country. What we are doing in Dublin is something very similar that we deliver for eating disorder patients in Donegal or in Kerry or Clare. So my main focus will be that it will be the same service delivered, because clinical programs are especially for small cohort of people, but very, very important people who a lot of resources, like eating disorders, people who present with self-harm, early intervention in psychosis, perinatal psychiatry. These are the things which were never there before, but clinical programs have given us an opportunity to develop those ones and deliver. Dual diagnosis is another example where mental health and addiction services we are trying to build, working together, how we can develop services for them around the country. It's not a problem in Dublin anymore, it's everywhere now. So we need teams everywhere in the country, and that's what we are doing. And I think with the RHS structure, that will be our focus going forward.
And briefly, Sean, we're turning into pumpkins shortly, so if you could...
Just to give you a nice example of the natural tensions in our discussions in NIMC, I would have completely the different view in terms of the need for spreading. I was involved in the National Clinical Programme for Self-Harm, also in terms of psycho-oncology developments within the National Cancer Programme, and also the Perinatal Mental Health Programme. And each of those programmes were focused on developing in each area simultaneously the growth and development of teams. I've seen the challenges of pilot programmes working really well in one small area or two small areas in the country and not available nationally. So there's a lot of cross-dialogue around this, but I do think it's something that's going to be key with the regional health authorities to maintain, and I think one of the features we focused on in the women's mental health was the essential importance of data collection. If we don't have data to be able to begin to compare what's been done across different areas, then we have no ability to influence standardization and improvement of services overall. So I think the data collection, the introduction of the new IT system as part of sharing the vision, I think is, I would say, at the heart of our ability to be able to translate active change.
Okay, we've got 20 seconds, 30 seconds each. What should be a priority in the second term of NIMC? Might start with you, John.
I think to try and keep the focus on the business, which is the policy and implementation, and to respect and understand what's happening out there which might cause problems. And I can see the regionalisation issue as one that might take up a lot of energy and detract sometimes from policy. And secondly, we're always living with money and the economics. And if economics change, there certainly will be issues around mental health.
Perfect. Maybe Amir?
Yeah, no, during this term, we had certain specialist group like acute bed capacity review. I think we need to make sure that it's implemented going forward. If we have a specialist group with youth and child mental health, now we have a proper governance. We need to make sure that it delivers it. It has the opportunity to develop and deliver. And certainly, when we'll sit with Catherine, with the new group, we'll certainly try to focus some of the new areas that we want to look into and see how we can develop that focus and start developing those services.
Super, thank you. Siobhan McHale?
Thoughtful data collection with resources available to actually be able to achieve that data collection.
Great stuff. And final word to you, Siobhan McArdle.
To continue the communication and collaboration, I think it's been a great example of how communication and collaboration, both collaboration to turn concept into actual real services that make a difference, and then communicating it through data, communicating it through learning, and using that learning to improve in the next step. I think also achieving the 42 short-term goals in the next year will be a real critical priority for the department as well. Thank you.
Absolutely. Thank you very much. And thanks very much to our panel for their time this morning. Thank you.